She walks like an angel walks. She talks like an angel talks. And her hair has a kind of curl.
Welcome to the Top Surgery Chronicles. This episode will feature my recorded phone consultation with my surgeon. If you're considering top surgery, listen closely. This video might include a few questions you want to ask your doctor if you ever have a consultation.
She's my kind of girl. A pretty little face. That face just knocks me off my feet. A pretty little feet. She's really sweet enough to eat.
So, to answer your question of when they're calling, they don't have like a strict time or like a set time. He starts to do the phone consults at 3, and then he does them usually at like 3 to 5. I thought I would be like one of the first people to be called because I scheduled this a while ago, and they tried to get me to do one much earlier. But I guess not. That's fine. I hope they have the right phone number. I'm getting nervous though.
You'll be okay.
My tummy is getting rumbly. I wish there was a way to know if they have the right phone number for you. And I guess Grace and I are just gonna watch Guys Grocery Games until my phone rings.
Please know that I'm yours to keep, my beautiful girl. When you cry, a piece of my heart dies.
So, they have not called me yet, and their office hours are about to be up. So, I am very paranoid, and I just want to make sure they have the right number, and I'm still on the agenda, and things like that. I'm also worried that maybe my photos didn't send through, and you need to have the photos before the consultation. I don't know. I'm very nervous, and my brain is just going 100 miles an hour with reasons they might not be calling me, so I'm just going to be very annoying and call them.
Hello, and welcome to the office of Dr. Charles Garamoni. Dr. Garamoni's office?
Hi, I had a phone consultation scheduled today, and they told me sometime between like 3 and 5 Eastern Standard Time, and I was just wondering if that is still the plan. I just wanted to make sure you didn't, if I didn't give you the wrong number or something like that.
Oh, no. No, we're just starting our phone consults. We started late today. You are the next one that he's going to be calling.
Oh, okay, great, wonderful. Thank you so much.
You're welcome.
All right, have a good day.
Cool.
Okay, that's good. I just didn't want to sit here, for 3 more hours.
Which we would have done still for you.
Thank you. You're such a good booba. I sounded so awkward and scared.
You did sound pretty terrified.
A fella needs a girl.
It's Fort Lauderdale, Florida.
Just answer.
Okay. Hello?
Hello, this is Dr. Garamoni. Is Ash there?
Yep, this is me. Hi, Dr. Garamoni.
Hi, Ash. How you doing?
Good, how are you doing?
I'm good. Is it okay to talk?
Yes, and then my wife, I have you on speaker, and my wife is also going to be on the call with us. Her name's Grace.
That's fine. Hi, how you doing?
Hi, I'm good. How are you?
I'm doing good. Okay, well, let's go forward here. So basically, I got your photographs here, and it looks like you're interested in the double incision method. Is that correct?
I'm guessing that it's probably impossible to successfully have Perry on my chest. Is that correct?
No, not at all.
Okay, sounds good.
That's exactly right. I just did a consult with somebody on the phone where your chests are almost identical as far as size and shape, and they went to Mexico and had the surgery done. They did a Perry procedure, and now they're like half their breast is dead. It's like awful. It's just
Sure.
horrific.
I kind of tried to accept that a while ago. But okay, sounds good. Double incision.
But honestly, the double incision method, you're going to have a great result because it's going to give you a very uniform, flat contour of the chest, be able to precisely place the nipples where they need to be, make them smaller, and it'll a million times better than any other procedure somebody can do. All right, so let me start. I'm going to ask you a few questions about your past medical history. Have you been seeing a therapist or a physician who's going to write you a letter to recommend chest surgery?
Yes, I have been seeing, a therapist. So that was another question I had. So you require a letter?
Would you require a letter? It could be from your family doctor if you want, or if you have somebody who's more familiar with you than your therapist, that's totally fine.
Okay.
Are you on testosterone?
I am not on testosterone.
Do you identify as male?
No, I do not.
Do you identify as gender neutral or gender variant?
Yes.
Do you have family, friends, or a partner that obviously have a partner, but do you have family or friends who are supportive of you having surgery?
Yes.
Are you allergic to any medications? And do you take any medications? Have you ever been diagnosed with high blood pressure, heart disease, or asthma? Have you ever been diagnosed with diabetes, thyroid problems, blood clots, or bleeding disorders. Have you ever had surgery before? Do you smoke? Do you drink alcohol, even socially? How tall are you? What is your current weight? Okay, so the double incision method surgery, the cost of the surgery, my surgical fee is $6,500. A hospital and anesthesia fee is $1,625.
Okay.
And we do this as an outpatient, so you get to go home the same day. Patients typically travel into town about a day or two before surgery. We meet in the office, go over the surgery in detail. We do the surgery the next day. About a week after surgery, that's when I'm going to have you follow up in the office. We'll take out the drain, take dressings off your chest. I'll teach you how to take care of your chest, and then you can go home. So most patients are in town for just about 7 or 8 days.
Okay, sounds good.
But aside from that, do you have any questions for me about the surgery?
Yes, I have a few questions. So first, based on my pictures, I was wondering what you think my scars are going to look like, if they'll be straight, what the placement will be, if they'll touch in the middle, things like that.
Well, I always try to make them straighter. I think straighter is the way to go, okay?
I agree, so that's good.
Yeah, it gives a more masculine look to the chest, and that's what most of my patients are going for, a more male or masculine-looking chest. I try to place it in a position that kind of hugs the lower border of the pectoralis muscle. Yours should not join in the center. I don't see that being an issue unless when you show up here in my office, for some reason, I can't see in the photos, you have a ton of breast tissue in the center of your chest.
Okay.
Which I don't think that's the case.
Awesome. I really would rather them not touch in the middle, so that's good news. Oh, so my wife and I haven't ruled out the option of me potentially carrying a child in the future. So we were wondering how like pregnancy works with like a post-op chest. If I were to get pregnant and my body were to like create the hormones that happen with pregnancy, if it would affect my post-op chest in any way.
It should not. If you have the really majority, like 95+% of the breast tissue is removed, so the remaining breast tissue, which is just so small and scattered, should not get engorged or anything like that. If it does, it's going to be very minimal. But ultimately, you're not going to grow breasts back. It's not going to affect your long-term results or anything like that.
Awesome. That's wonderful. I have quite a few questions for you. I hope this is okay.
Sure. Go right ahead.
I was wondering if there's any additional cost if I need any revisions.
Okay, yeah. So basically, this is how my revision policy works. If it's a small, tiny little revision that I can do in my office, I do that for free. My office is not set up for doing anything really extensive because it's mostly an office to see patients post-operatively. If there's anything that needs to have a major revision where we have to go back to the hospital, we go to the surgery center, then the surgery center would actually charge you for their fees, but I still would not charge you any of my fees.
Okay.
So, again, that's rare. I mean, you would have to, get in a horrible car accident and your incisions rip open and have a horrible scar, and then we go back and fix it. That's different.
Okay, awesome. So you don't have many people who need revisions?
Very rarely. Very, very rarely.
Okay, cool.
You're always going to have somebody if you do enough surgeries, you're going to do revisions on people. That's just normal.
Mm-hmm.
I do about 500 of these surgeries a year, and I take back, really not that many.
Okay, that's awesome. That's really good to hear. And then, what are the complications that could arise from surgery, and how many people usually suffer from any kind of complication?
Less than 1% of patients that I do surgery on develop complications. The most concerning one, obviously, is going to be bleeding immediately after surgeries, where you develop the hematoma.
Okay.
That's very, very rare. Then there's other things, like wound healing issues, nipple healing issues, things like that. But again, they're all still pretty rare.
I was wondering what the difference is between top surgery like this and a double mastectomy, because my wife might have to have a preventative double mastectomy in the future, and we're just wondering what the difference is.
They're pretty similar. It's just that, with this particular procedure, you don't want to leave behind any contour irregularities. Typically with a normal mastectomy, they're removing close to 99% of breast tissue, and they'll take out tissue even if they know there's going to be a big divot in the chest afterwards. With this surgery, that's not what I do. I take it out and make sure everything is smooth, uniform. If an area looks like it's getting too thin, I leave tissue there just so it doesn't drop in and give you this, that what we call saucer deformity or a depression in the chest, because we don't want that.
Sure. Okay. Interesting.
I have a breast cancer gene. Is it possible to do, because I think I might be eligible for peri, is it possible to do both or something like that to where I wouldn't have a divots or something like that in my chest?
She wants top surgery as well, so what she's wondering is, is it possible to get top surgery and not need a double mastectomy? Or are they too different?
They're different procedures. If you're doing it prophylactically to prevent breast cancer because you have a strong family history, I always recommend patients have it done according to the standard of care, which is going with a breast oncological surgeon, and they do a formal mastectomy.
Okay.
And unfortunately, it doesn't give you the best results afterwards. But the idea is you're preserving life, because chances are, if you have a BRCA1 or BRCA2 positive genes,
yep, that's her.
nearly 100% going to develop breast cancer in your lifetime, and this will help decrease that risk tremendously.
Ah, shoot. That's kind of a bummer. Oh, well. That's good to know, though.
With this particular procedure that I do, you gotta remember this. You still have to look at it. Even though it's like a mastectomy, it's a body or chest contouring procedure. It's not a breast cancer treatment. It's not. You know what I mean? Yeah. No, I have had patients in the past who have come to me, and I did one documentary several years ago where it was a patient who had a previous history of breast cancer. They wanted to have the formal mastectomy done. They wanted to do it the top surgery, and we did it and everything. And I was always kind of uneasy about it. I wasn't really a big fan of it. So it can be done, but I prefer patients to really go the standard of care route. I just think it's better.
Sure.
Because you do the surgery, and then 2 years later, let's say you came down with breast cancer, because I had to leave behind some breast tissue because I didn't want the contour to be wrong. And then it's like, okay, now you got breast cancer. I'm going to feel horrible that you got breast cancer, number one. You're going to feel bad because then you got breast cancer.
Right.
And we're going to be like, why didn't we just have the entire mastectomy done the way it should have been done according to the standard of care?
Sure, no, that makes sense.
All right. I think that's all the questions that I have. Well, thank you so much.
All right. You're welcome. Great talking to you both.
Have a good one.
Thank you.
Bye.
Okay. All right. Bye.
I think he was very informative. I was warned beforehand that, the call is going to be very, to business. Mm-hmm. Don't expect your surgeon to be, your best friend. They're not super warm and fuzzy. And like he said, he does 500 of these a year. There's only 365 days in a year. Yeah, so he answered all my questions. And I don't know. I think I feel good about it. All right. Cool.
I'm a girl, and by me that's only great. I am proud that my silhouette is curvy, that I walk with a sweet and girlish gait, with my hips kinda swivelly and swervy.